Forget everything you've been told about where nerve damage starts. You've been watching your feet, checking for numbness in your toes, waiting for tingling to creep up from below. And that is exactly why so many people miss it. A large nerve conduction study tracking over 1,000 patients with early peripheral neuropathy found that in a meaningful subset of cases, measurable nerve slowing showed up in the hands weeks to months before the feet ever registered a problem. And here's the twist that should unsettle you. The people most likely to miss this are the ones who consider themselves careful, the ones who already check their feet every night, who think they've covered their bases. I've spent years reviewing nerve studies and patient charts, and the pattern is consistent enough that it deserves your full attention. In the next 20 minutes, I'm going to walk you through exactly how nerve damage can announce itself in your hands first, why your doctor might miss it on a routine visit, and the specific signs that separate an ordinary case of sleeping on your arm wrong from something your nervous system is trying to warn you about. Here's what you're going to walk away with. Promise number one is the exact hand symptom, not tingling, something more specific that shows up before classic numbness does. Promise number two is a simple 2-minute test you can do tonight with nothing but a coin and a piece of paper. Promise number three is the one blood marker that predicts hand-first nerve damage, and it is not the one most people get tested. Promise number four is a list of the medications and conditions that make hand-first patterns far more likely, so you know if you're in a higher risk group. And promise number five is the exact 3 questions to bring to your next doctor's visit that force a real answer instead of a shrug. Before I get to any of that, I want you to hold on to one thing. There's a piece of advice almost everyone repeats about nerve damage, something you've probably heard from a well-meaning doctor or read online that turns out to be only half true for a specific group of people. I'll come back to that later, and when I do, it's going to change how you think about your own risk. Let me start with Daniel. 52 years old, lives outside Denver, runs 3 miles most mornings with his dog, eats the way a magazine would tell you to. Daniel is, on paper, the person who does everything right. About 18 months ago, he noticed his right hand felt clumsy buttoning his shirt. Not numb, just slow, like his fingers weren't quite listening. He assumed it was a pinched nerve from sleeping wrong. 3 months later, he started dropping his coffee mug without warning. No pain, no numbness, just his grip letting go. His A1C, the standard 3-month blood sugar marker, was 6.1. Technically pre-diabetic. Technically not bad. Nobody flagged it. At his annual physical, his doctor's note read, mild insulin resistance, monitor. 9 months after the button clumsiness started, Daniel woke up unable to feel the difference between hot and cold water on his right hand, and an ER visit turned up nerve conduction velocities in his hands that were already moderately reduced. The warning sign had been sitting in his chart the entire time, a slowly climbing fasting glucose, visible across 4 consecutive lab panels, and nobody connected the dots, because each individual reading looked borderline fine. Daniel is not the exception. Roughly 1 in 3 adults with prediabetes will go on to show measurable peripheral nerve changes before they're ever formally diagnosed with diabetes. And in a meaningful fraction of those cases, the hands are where it shows up first. Now contrast that with Priya. 34, lives in Austin, works as a graphic designer, no family history of diabetes, no risk factors that would put her on anyone's radar. Priya's mechanism was different. Not metabolic, but mechanical and autoimmune, layered on top of years of repetitive hand use at a keyboard. She started noticing a strange electric zinging sensation shooting into her ring and pinky fingers whenever she bent her elbow a certain way. Most people brush a symptom like that off as nothing, a pinched nerve, a bad night's sleep, and most of the time, that's exactly what it is. But when that zinging sensation happens repeatedly over more than a few weeks, especially alongside any weakness in grip, It stops being a coincidence and starts being a signal. One clinical review found that a meaningful share of patients who ignore this kind of recurring nerve irritation for more than 6 months go on to develop measurable, sometimes permanent muscle wasting in the hand. Priya didn't ignore it. She brought it up at a routine visit almost as an afterthought, mentioned it took a full minute of the appointment, and that single sentence led to an ulnar nerve study that caught early compression before any lasting damage occurred. Her near miss is the version of this story that ends well, and I want you to notice why. Not because she had better luck than Daniel, but because she said something out loud. Then there's Marcus, 61, retired teacher outside Cleveland, and by every conventional number, his health looks close to ideal. Normal fasting glucose, normal reflexes on exam, normal grip strength when tested once in an office. Marcus's story doesn't have a dramatic single reading that should have caught anyone's attention, because the danger was never in any one number. It was in the trend. Marcus happened to be part of a research cohort that measured vibration sensation thresholds in the fingertips every few months. Month 1, normal. Month 4, a small, almost negligible increase in the vibration threshold needed for him to feel it. Month 8, another small increase. Month 14, still within the normal range on any single test, but the trajectory over that year and a half was unmistakable once you plotted it. A slow, steady decline nobody would have caught from a single annual physical. This is a case that proves the entire thesis of this video. The danger was never the single data point. It was the pattern nobody was tracking. Because Marcus was being monitored over time, his nerve specialist caught the trend early enough to identify a treatable underlying cause, a subtle vitamin B12 absorption issue, months before it would have become symptomatic. He's fine now. This is the version of the story where the system, when it's actually paying attention over time instead of taking one snapshot, works. So why does this happen in the hands at all? And why does it sometimes beat the feet to the punch? Picture your longest nerves as garden hoses, running from your spine all the way down to your toes and all the way out to your fingertips. The classic teaching is that the longest toes, the one running to your feet, gets damaged first, simply because it's the longest stretch of vulnerable tissue. That's true in the majority of metabolic nerve damage, which is why check your feet became the standard advice. But nerves aren't just long tubes. They also pass through narrow mechanical tunnels at the wrist, at the elbow, the way a hose can get pinched where it bends around a corner. When damage comes from compression, from autoimmune inflammation, or from a localized process rather than a purely length-dependent metabolic one, the hands, with their tight anatomical tunnels, can become the pinch point that shows trouble first. This is exactly what happened with Priya, whose ulnar nerve narrowed at the elbow long before her feet were involved at all. It's part of why Daniel's early symptoms showed up in his fingers, even though his ultimate diagnosis was metabolic. His particular nerve anatomy happened to make his hands the more sensitive early warning site. And it's the invisible thread running through Marcus's case too. His declining vibration sense in the fingertips was the most sensitive available early marker, precisely because fingertip nerve endings are so densely packed that small losses show up there before they'd be detectable anywhere else. Here's the piece of nuance most people have never heard. Nerve damage doesn't follow one universal script. Clinicians increasingly describe a threshold effect, where nerves can tolerate a surprising amount of subtle stress before symptoms appear, and then cross a tipping point fairly quickly. That's why the story so often looks like nothing, 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 then suddenly this. When in reality, the trend was there the whole time, just below the threshold of a single test. So here's what to actually do about this, starting tonight. Step 1. Do the 2-item test that costs you nothing. Take a coin, close your eyes, and see if you can identify it by touch alone, using only your fingertips, comparing one hand to the other. A clear one-sided difference is worth mentioning to a doctor, even if it seems minor. Step 2. Track your grip, not just your sensation. A basic hand dynamometer runs about $15 to $25 online, takes under a minute to use, and this is the mistake almost everyone makes. Most people only think to test grip strength after they've already noticed a problem, instead of establishing a baseline while everything still feels normal. Test it now, write the number down, and retest every 3 months. That's the promise from the top of this video. The range you're looking for is consistency within about 10% of your baseline, not some universal, normal number, because your own trend is what matters. Step 3. Ask specifically for a vitamin B12 and fasting glucose panel at your next visit, not just a general metabolic panel, because B12 deficiency and prediabetes are two of the most common and most overlooked causes of hand-first nerve symptoms, and they're often not automatically included together. Step 4. If you notice any repeated electric or zinging sensation into your fingers, especially with elbow bending, mention it explicitly, rather than waiting for it to become painful. Bring 3 specific questions with you. First, can you check my vibration sensation threshold today, not just my reflexes? Second, based on my glucose and B12 results, am I in a group where hand-first nerve changes are more likely? And third, is there a reason we're not ordering a nerve conduction study given these specific symptoms? Each of those questions requires a concrete answer, not a reassurance. Step 5. Know your exception groups. People on long-term metformin who are at meaningfully higher risk of B12 depletion. People with any autoimmune diagnosis whose nerve inflammation can behave completely differently from metabolic damage. And people whose jobs involve repetitive gripping or leaning on the elbows, who face mechanical compression risk regardless of their metabolic health. Now, back to that open loop. The well-meaning advice you've probably heard is, check your feet daily for nerve damage. And that advice isn't wrong, it's just incomplete. It was built primarily around length-dependent diabetic neuropathy, the most common pattern. And for most people with that specific mechanism, it's genuinely good guidance. But as Marcus's case shows, if your nerve changes are driven by a slow nutritional or autoimmune process, rather than pure length-dependent metabolic damage, foot checking alone can miss the earliest and most sensitive warning signs entirely. Because the fingertips may be losing sensation on a measurable trend line long before the feet show anything at all. The fix isn't to abandon foot checks, it's to add fingertip vibration and grip tracking alongside them, especially if you fall into one of the higher risk groups I just named. One more move, and this one is conditional, so only take it if it applies to you. If you've already noticed any asymmetry, one hand clearly different from the other on that coin test, ask your doctor specifically about a referral to a neurologist for formal electromyography, rather than staying in general practice follow-up alone. If your numbers and symptoms are symmetric and mild, this step isn't necessary yet. Simply keep tracking. And to be clear, everything in this video is educational, not a diagnosis or a treatment plan. Any decision about testing or referral should go through a licensed medical professional who knows your full history. If you want a simple way to actually track this instead of just remembering it, I put together a free nerve health tracking sheet. It includes a monthly grip strength log, a fingertip sensation checklist you can do in under 2 minutes, and a 1-page list of the exact lab values to ask for at your next physical. You'll find the link in the description. If this video helped you see something you hadn't considered, subscribing costs you nothing, but every person who does helps this reach someone else who's currently ignoring the same small, clumsy feeling in their hand that Daniel ignored for 18 months. And if you have a parent on metformin, or a partner who spends all day at a keyboard, send them this video before their next appointment, not after. Because the version of this story we want for everyone watching is Priya's and Marcus's, not the one where the answer was sitting in the chart the whole time and nobody said it out loud. This video is for educational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment.